Welcome back to Your Health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm very pleased you could be with me for this second segment. My next guest is a distinguished board-certified cardiologist, Dr. Soteria Karahalios. Dr. Karahalios, thanks so very much for coming on the program.
Thank you for having me on.
You have a lot of stuff going on professionally. You are a board-certified cardiologist, and you have some new services that you offer through Prima Heart. Isn't that correct?
Yes.
Prima Heart.
Yes.
So let's start off by talking about the training for a cardiologist. How do you start off? And I want to talk about how you developed an interest in cardiology. So where'd you go to medical school?
University of California, San Francisco.
Oh, not too far away.
Not far away.
So medical school's 4 years.
Right.
And then what?
And then medical internship. And then 2 years of medical residency, general straight medical residency. And then I did 3 years of fellowship in cardiology. And then did an additional year in an area called gerontology with a focus on cardiovascular disease and aging. And then went into private practice after that.
Dr. Karahalios, some people might say you're an overachiever, but you certainly have terrific training.
Yeah.
So isn't it true that after your internal medicine, training, you could have practiced internal medicine,
yes,
but you decided to go on to cardiology?
Correct.
So, tell us what preventative cardiology is.
Well, traditionally as a cardiologist, we manage heart disease, acute and chronic heart disease and vascular disease, people presenting with heart attacks, heart failure, stroke, angina, which is the chest pain that one gets from clogged arteries or atherosclerosis, arrhythmias, but these are pretty active, established points of heart disease. And at every step along the way, we're geared and oriented to prevention, but at that point, we're oriented to preventing an adverse cardiovascular event, having a heart attack, damage to the heart, sudden death, and intervening very aggressively at that point. But unfortunately, when the diagnosis comes, it's often later in the spectrum of heart disease. About 2/3 of individuals who end up who have heart disease, the first event is either a heart attack or sudden death. 1/3 of the time, people are fortunate because they have some warning signs or premonitory symptoms, and in those individuals, that's when we get in aggressively and do diagnostic testing and angiograms and can put in stents and all of that. Those interventions, bypass surgery or valvular surgery if needed. However, ideally, it's better to try to focus on preventing heart disease earlier in the spectrum. We know now that heart disease starts early on, either in our youth, for sure if they're obese, in young adults, and it's very silent over decades, in our 20s and 30s and 40s. And sometimes it's valvular disease, but what we worry about most is the buildup of plaque in our arteries, atherosclerosis. And the unfortunate statistics are 1 out of 2 women and 2 out of 3 men will die of either heart disease or stroke. So it's very, very important to focus early on at the start of the very beginnings of the disease and intervene in trying to prevent the risk factors that cause the progression.
Well, Dr. Karahalios, those are startling statistics.
They are.
1 out of every 2 women and
right.
2 out of every 3 men
right.
will suffer from severe heart disease.
Heart disease, a heart attack or stroke, exactly. And to put it in perspective for women in particular, because I see a lot of women, one of my areas of focus is women and heart disease, is we're very concerned about cancer and breast cancer, and as you just heard about screening. But 1 in 33 women will die of breast cancer, but 1 in 2 will die of heart disease. So as importantly to focus on breast cancer detection and screening, we need to focus on a regular basis on detection of heart disease early and intervening early.
Well, Dr. Karahalios, how does a person be identified? How do they identify themselves? How do you identify them as being high risk?
So we focus on in risk assessment or looking at the profile of that individual. So we definitely focus on what their risk factors are. Now, age is a very dominant risk factor. The older we are, the more likely that we're going to get buildup of plaque in our arteries or may have some aspect of cardiovascular disease. But the other primary risk factors are genetics, having a positive family history, and that means a primary relative, mother, father, sister, brother, who had a heart attack or a stroke or a cardiac event in their 50s and 60s. So grandma having a heart attack in her 80s doesn't really constitute a positive family history. But genetics or positive family history is one primary risk factor. High blood pressure, high cholesterol, the presence of diabetes, a very strong risk factor for development of early cardiovascular disease, and smoking. These are the primary risk factors. We also know that obesity is a risk factor at this point, and particularly in those individuals who are 30 pounds or more overweight. So we're very oriented now into assessing individuals for presence of cardiovascular disease if they are significantly overweight or obese.
So let's say someone has a feeling themselves that they're at high risk. Let's say they have a very heavy family history. Maybe they have diabetes, maybe they're overweight. They've been told that high cholesterol runs in the family.
Correct.
How do you approach that particular patient to determine whether or not they are actually at high risk?
Well, we first take a very, very careful history. Look at all the risk factors. Particularly if a woman is postmenopausal, the risk goes up in the 5 to 10 years after menopause and continues to escalate after that. If there's a strong family history, we definitely scrutinize those individuals even in their 30s and 40s, definitely early on. We now screen and test for cholesterol in children and adolescents. The guidelines start at age 12. So pediatricians are out there now assessing cholesterol, particularly if there is a strong family history. So even in kids, it's never too early to start with checking a lipid profile or doing cholesterol testing. We definitely recommend it in young individuals. Get a baseline to determine do you have an abnormal lipid profile, and it's not only looking at the total cholesterol, it's looking at the LDL, which is the bad. I say L is for lousy, the bad cholesterol. The HDL is for the healthy cholesterol, and the other elements, the triglycerides, and also fasting blood sugar. Some people don't necessarily have to be overweight to have elevated fasting blood sugars. So getting some assessment of what their risk is important in terms of a profile if they're asymptomatic. If they're having any type of symptoms, then that means taking a very careful history or assessing them perhaps with a stress test is also very, very helpful.
So what type of symptoms may indicate to a person that they're actually at high risk for cardiac disease? For symptoms,
so chest pain, either typical chest pain, which is usually a pressure or a tightness or squeezing in the chest, in the sternal area, the mid-chest, or it could be left-sided. However, in women, chest discomfort can be very atypical. It can be neck or jaw pain. It can be atypical shoulder discomfort or upper back discomfort. Can be symptoms that mimic heartburn, and so those are types of atypical discomfort we look for. Shortness of breath with exertion, sometimes episodes of profound weakness, fatigue, dizziness, palpitations, any suggestion of arrhythmias all may indicate that there may be some underlying heart disease present.
Okay, so Dr. Karahalios, let's say that we identify a patient as high risk because of either their family history or comorbidity factors such as diabetes, obesity, etc. What specific tests or what steps do you take to actually determine their actual risk?
So what I do and what most primary care physicians might do at an annual checkup, or gynecologists as well, will be definitely a lipid profile, fasting blood sugar. We will do thyroid function tests, screening thyroid function tests, because having an underactive or hypothyroidism can also be associated with increased risk. We might do a baseline electrocardiogram. Generally, we do. It often can be normal, even though somebody is at risk. In some individuals, we do something, some biomarkers, something called HSCRP, high sensitivity reactive protein. It is a biomarker of inflammation. It's a blood test. It can be associated elevated in a non-specific way in some individuals who are sick, if they've had a recent upper respiratory illness or pneumonia or bronchitis. However, in an otherwise normal, healthy person, shouldn't be elevated. Now, some people who have rheumatoid arthritis, lupus, other kind of inflammatory disorders, it may be elevated. They are often at risk for higher risk of heart disease. So it sometimes is very, very helpful as a marker that there is increased inflammation. The process in our arteries of buildup of cholesterol and plaque and is an inflammatory process. And there are certain things that gear up that inflammation and other things, a lot of our therapies and good lifestyle modifications that cool down that inflammation, and that's the goal. So we want to know if there is active inflammation present. So we often use it as a biomarker or indicator that there might be some increased risk. The other tests that we often do are a treadmill stress test. Sometimes we combine that with some of our imaging modalities like ultrasound, as we do for mammography. We do an ultrasound of the heart. We also can image the arteries in the neck, the carotid arteries, with ultrasound, and that gives us an indication if there's plaque present. If there's plaque present, that means the process is already started, and it's very important to start getting very aggressive about intervention.
Well, that's fascinating. Now, let's say that we have a patient who you have identified as high risk. Is there anything a person can do to actually lower their risk
Absolutely.
of, say, a myocardial infarction, what's commonly called a heart attack?
Yeah, and that's the whole goal. The earlier we can identify if somebody's at risk and detect the early beginnings of the disease, the more that we can put certain things in place. The basic foundation of good intervention is basically diet, exercise, and a good lifestyle, not smoking and being active. In some individuals, there's a need for blood pressure medications. There's also a need for lipid-lowering medications, some of the statin medications. When to intervene with beginning aspirin in a prophylactic way preventatively is also very important. In women, it's at age 65 unless there's some contraindication. But if someone's higher risk, or in a man who tends to get heart disease about 10 years earlier, you move that age group to about 50 or 55. If somebody is at much higher risk, even in their 40s, they may even go on aspirin or a statin medication much, much earlier.
So it sounds like there's a lot that a person can do to take more responsibility
Absolutely.
for their health and actually lower their risk of a bad cardiac event. They
can lower their risk substantially, whether they're at low, intermediate, or high risk. What we know now is that it's not only what the risk is at any point in time in their 50s or 60s, but even an individual in their 30s and 40s, what we know is if you look at their lifetime risk of developing heart disease or stroke, it may be much higher than their risk at age 30, when they might be deemed at lower risk.
Dr. Karahalios, I know you're certified for cardiac CT angiography. Isn't that one pretty sophisticated test that people can get to assess their risk? Or?
It is. It's a good early disease detection test, absolutely. We do two types of testing, coronary calcium scoring and also coronary CT angiography. With calcium scoring, one lies in a CT scanner, and in a matter of a second, it's actually literally a heartbeat, but a second or two, we can image the heart, and if there is calcified plaque within the coronary arteries, it's picked up on the scanner, and it generates a score. That score then translates, there's a huge database in the United States, something called the MESA study, and based on one's age, gender, and their ethnicity, it translates to a percentile. And that percentile of risk, if someone's at the 95th percentile at age 50, they're at substantial increased risk. But it's across the board, if somebody's 30 or 40 or 60 or 70. And that is an early disease detection test. It doesn't necessarily tell us that there's obstruction in the arteries or that the heart attack is imminent. It just says that the higher the calcium score, the more the risk, the process is established. With CT angiography, we actually can inject a little bit of dye in a vein. It's still considered a non-invasive test. It's not like a traditional angiogram. But that will pick up the earlier plaque before it's calcified, the soft, early lipid-rich plaque, which often tends to be the more vulnerable plaque, prone to rupture.
Okay, so you mentioned non-invasive or minimally invasive workups and testing. Now, that's as opposed to, say, a cardiac cath,
right,
or an actual angiogram. Can you teach our audience about the difference between a cath and angiography as opposed to these non-invasive or minimally invasive tests?
Right. So a cardiac catheterization or coronary angiogram is done in a hospital setting. It can be done in some other settings, but usually it's a hospital setting. A catheter is placed into the artery through usually either the arm or the leg, and under fluoroscopy, guided up into the openings of the coronary arteries, and dye is injected. And we actually take a picture of the arteries of the heart, looking for evidence of obstruction in the arteries. When we do a coronary CT angiogram, the non-invasive version of that test, it's just an IV that's intravenous in the arm, and it's literally a little bit of dye, not like the dye that you get in a coronary angiogram, and it gives us not only an image of obstruction in the arteries, but it also tells us if there's plaque present. We can actually visualize in the wall the presence of either soft, non-calcified plaque or calcified plaque.
Well, that's fascinating. We have only about a minute left, Dr. Karahalios. This is fascinating to me. I hope you come on again. Let's talk a little bit about the Prima Heart.
Okay.
Okay, now you have a private practice, of course, and you have the Women's Heart Center on Cass Street in Monterey. But tell us about this sort of collaborative effort with the City of Monterey at the Monterey Sports Center. That's
Yes.
fascinating to me.
Yes. So it was an idea put forth by the City of Monterey. They're very much very supportive of it and getting it started. Integrating in a fitness facility the combination of preventative cardiovascular services, programs, some of this early diagnostic testing, cardiovascular screenings, fitness programs, providing some medically supervised fitness for individuals that need it, that have a spectrum of health needs, as well as a lipid program, lipid management program, or cholesterol management program, women's heart disease, and some youth and teen obesity, as well as educational programs.
And that's right at the Monterey Sports Center?
That's right within the Monterey Sports Center. It's the first time in California. There have been a few places in the United States that have begun such a concept, but it's the first one in California that integrates medical preventative cardiovascular programs within a fitness facility. Of course, you have that at wellness centers and outpatient facilities and at spa resorts, but the first time that it's in a fitness center, so we're very excited about it.
Oh, I think it's fascinating. It sounds like a great idea and a great service for the public.
Yeah, we hope so.
Dr. Karahalios, I want to give out your number, okay, if someone has questions about their risk or they want to be seen, okay? You are here in Monterey. Your office is 333-1345.
Correct.
I'll say that again, 831-333-1345. Dr. Soteria Karahalios, board-certified cardiologist, specialist in preventative cardiology.
Thank you.
Dr. Karahalios, you're a terrific teacher. Thanks for being here.
Okay, thank you for having me.
Hope you come on again.
Yes.
This is Your Health television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon. We're going to take a very brief pause for a very good cause.